that we couldn't have this in person, but this is the next best thing. So I'm glad that we're still continuing to have this discussion, whether it's virtual or in person. Hopefully next year we can all meet at the Rural Conference again. So my name's Ty, like Hannah said, and I wanted to just give a quick overview on the Wyoming Telehealth Network and our efforts with telehealth in Wyoming. So the Telehealth Network is housed within the University of Wyoming, Wyoming Institute for Disability and College of Health Science, and we are funded through a contract with the Wyoming Department of Health, and so they are our key partners in the implementation of this network, along with the Wyoming Telehealth Consortium, which is a legislative mandated consortium that is all of us together, the Department of Health, the Wyoming Telehealth Network, and the consortium are all here working together and trying to push the needle forward as it relates to improving access to care to Wyoming residents through the utilization of telehealth. And so at the Telehealth Network, I just wanted to give a quick overview as to what we do provide. Not only do we provide access for providers for a platform, so we provide free HIPAA-secured Zoom licenses to telehealth providers that want to provide telehealth utilizing our Zoom platform here in Wyoming. If you are a provider and you are looking for a platform and you want to get your toes wet with Zoom, you can certainly reach out to either Greg or myself, or go to our telehealth website or our telehealth network website and enroll. It's very simple, super easy enrollment process, and you would be given a HIPAA-secured Zoom license. We also provide, though, a variety of different services in order to help providers and healthcare organizations throughout Wyoming build capacity within their practices to be able to offer telehealth service. So whether that's training as it relates to best practices in telehealth, whether that's policy and procedure, consultation or guidance, or whether that's just one-on-one technical assistance with your platform or Zoom, or just the workflow that you have within your organization. So Greg, thank you for putting the website. The Wyoming Telehealth Network website is listed in the chat for anyone that's interested. We also provide monthly webinars, so that training and technical assistance piece, we facilitate the consortium now on a monthly basis for the foreseeable future. It used to be quarterly. We also have a variety of different resources on that website, from best practices to policy templates to a starter guide, or linkage to other national resources that's out there for telehealth. So that's a really quick, broad overview of the Wyoming Telehealth Network. Again, our mission is to support healthcare entities, providers, and specialists to increase access to care and improve health outcomes for Wyoming residents. And we do that through professional development, collaboration, and leveraging of our telecommunication technology, which is Zoom. So if there's any questions for me, I'm here to help Greg and Dr. Bush as they go through some of the questions. But with that, I'll pass it over to Dr. Bush from the Wyoming Department of Health so that he can give an overview of the department's efforts at a statewide level.
So thank you, Ty, and thank you to the Primary Care Association for hosting this meeting. The Telehealth Consortium was created by the Wyoming State Legislature in the year 2009 to promote telehealth. It is a jointly led by the Department of Health and our technology branch, which is called ETS. And it's open to all members of the public. Our meetings are public, so anyone who has any interest in telehealth, but we do meet with the Department of Health, with the Wyoming Board of Medicine, with the Broadband Council, with all the hospitals. And I'm very proud of the fact that, you know, all the hospital networks are members of the Telehealth Network and Telehealth Consortium. The Department of Health has a strong mandate and mission to improve access to primary care and specialty care. And in the face of COVID, we have not only had CMS, Medicare, but the Blues and Cigna are also have really loosened their telehealth requirements, and we're even allowing telephonic. I've been very proud of the fact that we've been able to really improve access to primary and specialty care. And like I said, we're working with all the hospitals in the state of Wyoming and many of the providers. We've seen our numbers of telehealth providers leap from over 400 to over 2,000. And we are tracking the numbers who are accessing telehealth, and they are going up astronomically at this point in time. So if you've been thinking about it, this is really the best time. It's best for our patients to be able to access their health care. We've seen that hospital visits and doctor visits have gone down dramatically, but we have seen the numbers of telehealth visits going up. So I think we've really been able to avoid having a crisis in access to healthcare during this point of time. So if you have any questions about the consortium, the network, or the Department of Health's role, I often use the example that the use of state funds, it's like we build the roads. We don't tell people what to transport on the roads. So we are here to make it easier for our healthcare providers to service the population. So that's a brief background there.
Great. Thank you so much for providing that background information. So that brings us into the discussion portion. We have 4 topics that we're going to cover before we get into the Q&A. So let's get right into the first one. So discussion topic number 1, what does an ideal telehealth workflow look like? And could you kick us off, Dr. Bush, please?
Sure. A lot of people have the misconception that telehealth is some different animal, and it's really just healthcare provided via another medium. And so the best practices have been able to just blend them. So when you're scheduling, you schedule on the same systems that you normally do, but you just indicate it's a telehealth visit. If you're going with our HIPAA compliant Zoom license, which we make available at no cost to people, you just set up the appointment and forward that on to the patient. If the patient does not have adequate broadband access, then you can bring up your electronic health record and communicate with the patient via telephone. I've seen very successful practices. When Dr. Bartholomew was in Saratoga, it was a very small practice, and he was a huge advocate for telehealth, and it made it work very well. So again, what we have done is we have enabled any service that is appropriate to be done via telehealth, that we will go ahead and pay the same as if you were in person. And so I'm going to let Greg then walk through some of the other details. But the main point is you just get 1 or 2 people in your practice who are comfortable, make them the point person for telehealth, and just fold it into the rest of your practice. Most practices do a combination of in-person and telehealth visits. So Greg, do you want to take it from there?
Yeah, sure. And to follow up on what Dr. Bush was mentioning, the rule of thumb really is, telehealth is it's a service delivery method. It's not an entirely different animal when it comes to healthcare. So staff that would be doing scheduling, you can still schedule meetings. Nurses or staff that would be opening up an appointment or an encounter for vitals or a check-in or intakes can still do the same. Providers can still run their encounters, and folks who are doing billing can still do billing. So it's not going to radically alter what you're doing. It's just considering adding this extra component to it. So in lieu of thinking about that, it's not going to be wildly different, but you do want to have gone through all of the steps. So this means, going through your planning, and I know we're hitting the ground running right now. We don't have the time to sit and plan for 3 weeks or a month. But as much planning as you can do, even if it's planning in tandem with running sessions, training and meeting with staff, and ideally having some written guidelines and some policies or some procedures, just to make sure that everybody's on the same page. Particularly for smaller facilities, you do want to make sure that everybody is capable with using the telehealth platform that you're using, and that you do have your backup plans, that if there does need to be technical assistance or troubleshooting, that you do have at least a couple people that are capable of doing that in case there's an absence, or you have one really good tech person but they're busy. Larger practices, making sure that you have some point people, tech, IT staff that are both well trained and able to train and support staff and the and patients as well. And those are kind of like your big things to consider initially. So that's part dictated by the size and type of your practice, and then also the services you provide. So at least in meeting for an encounter, your in meeting workflow is going to look different if you're using peripherals or if you're just doing a straight face-to-face visit with video and audio. The equipment and software that you're using is also going to be your biggest indicator of what your workflow is going to look like. So Zoom, for example, it's a very streamlined, simple platform. It's not going to integrate by and large with most EMRs, with most documentation, with most patient portals, but it's really simple and easy to use. So you go in, you create your meeting, and then you schedule the invite in a separate email, copy the information over and send it to the patient. That's going to look different on a different platform. No matter what the platform is, even if it's another simple streamlined service like Doxy.me, or if it's something that's like very comprehensive, very robust, that like comes in and kind of takes over your whole practice, maybe like AMD or InTouch. So that's going to be a very big indicator. Then also if you're using a cart system or any peripherals, and that also kind of goes into patient access, which we'll talk a little bit more about in a different question as well. And Ty, did you have any additional thoughts?
No, I think that you guys went over it really well. Thank you.
Great, thank you. So that'll bring us to our second discussion topic: what to consider when evaluating equipment for telehealth. Dr. Bush, would you kick us off again, please?
Sure. So there is a lot of variability here. At its bare bones, all you would need in the days of the COVID crisis is telephonic communication. We think the video component really is an asset. You look at the bandwidth in your area, and we know that bandwidth has been an issue, but we've also seen successful combinations where, again, if the patient does not have internet access, then you can at least bring up your electronic health record and talk with the patient. You can also think about the use of peripheral devices. A lot of patients can have access to their own blood pressure monitors. There's scales. You can sometimes have them come in to get blood work drawn, and then you can go over that blood work results with them. Another thing that is really useful sometimes, and I should have mentioned in the first time, is you can actually bring together combinations. So you can have the patient in one location, the family in a second location, the primary care physician in a third location, and a specialist, say in Denver or Salt Lake City, in a fourth location, and they can all be together virtually at the same point in time. In terms of security, again, they have relaxed some of the HIPAA requirements, but we still offer our Zoom licenses are encrypted at both ends, so it's very secure. I really would encourage people not to use some of the more public-facing outfits like TikTok or whatever. And so that's sort of the basic thing. There are peripherals, and so like if you're in a nursing facility, you may consider having Bluetooth-enabled stethoscopes and otoscopes, ophthalmoscopes. but those aren't necessary. So you can really custom fit it. Of course, if you're providing mental or behavioral health, again, you don't need any of that sort of equipment. We've even opened it up to speech therapy, uh, uh, occupational and physical therapy, et cetera, where you can be watching the patient and coaching them through that time. So there's a wide variety of considerations. It really depends upon the patient and what type of visit. I'll turn it back over to Greg now.
All right, thanks. And I'm just going to take a slightly different look and a slightly deeper dive into some of what Dr. Bush has gone over, because he covered it really, really well. In terms to kind of go back to the primary equipment, yeah, you know, just for telehealth, really all you need is, you know, some sort of hardware, computer, laptop, tablet, smartphone, the internet, and, you know, audio and video. And that's really all you have to have in order to make telehealth work. You can certainly have peripherals, you can certainly have cart systems. You know, things like peripherals and you know, larger systems are going to be a little bit more difficult right now in terms of COVID-19, just with a lot of patients, you know, meeting with a lot of patients at home, and that's where considering remote patient monitor devices for folks that need them is really useful. For any providers or facilities that are coordinating with, you know, skilled nursing facilities or nursing homes, that does provide you an avenue for still being able to obtain vitals and actually being able to use peripherals and cart systems a little more easily, at least right now. But in terms of thinking about equipment, it's really helpful to think of like, well, what do we actually need right now, and what are things that we can add later as we know that they would be beneficial to our practice. You know, it's a case of not having to bite off more than you can chew. In terms of a good technology resource, because right now there's a huge influx of technology for COVID-19. You know, technology companies are some of the few companies that are not suffering too much. And a big consideration, you know, with all medical equipment, but particularly right now, is what is good equipment. And so the National Telehealth Technology Assessment Resource Center, more shortly known as TTAC, is a really good resource. And I'll pop that in the chat in a couple seconds. And that's good for going over reviews and assessments and information on different technology that's available. A really big thing to think about with technology is education and ease of access. And that's both for, you know, the provider and staff side and for the patient side. Some platforms are really simple and easy to use. Some are much more comprehensive. But every single platform, it's going to take a little bit of learning and a little bit of education to get used to. You know, patients used to just come in, they'd drive over to the clinic or the facility, and they, you know, meet in person. And now really they just have to click a button, but they might need to download a program or something like that. And thinking about what are the least number of steps that the platform that you're using is going to involve, or if you're using remote patient monitoring equipment, what are the steps that need to go in place for that? Does it integrate with maybe the telehealth platform that you're using? Just a note on security, with the telehealth network providing HIPAA secure Zoom accounts, this does provide, you know, I think a really useful no-cost solution for people that might need to consider some of the other video chat options right now with the relaxed HIPAA policies. But pretty much every single telehealth platform is going to be HIPAA secure. It's going to have a HIPAA secure option. And really what maintains that HIPAA security is the business associate agreement. And what that means is that the company itself can't even access the patient information. And that is the main distinction between your regular telehealth platforms and the platforms that are now available with relaxed HIPAA guidelines like FaceTime, Facebook Messenger video, and WhatsApp. And all of these are going to be, you know, encrypted to a certain extent, so outside entities really won't be able to get in. But that doesn't mean that these companies don't have all of the access to all of the patient information being shared during those appointments. So if those are platforms that you do have to use, and maybe it's a situation where a patient really needs to meet and they really want to, use FaceTime for some reason, or if you really have to, being able to guide patients through that and be like, companies can still see and hear everything that you're talking about, possibly, and being able to consider that. And definitely no TikTok or Instagram or live streaming, which kind of just goes into your regular typical security practices, which is the big thing with security. Anything that you would consider in an in-person encounter is something that you would consider now. Where are you? Where is the patient? If you're delivering care from home, making sure your kids or your family members aren't running in and out, or that you have a headset, and just maintaining your own technology hygiene for communicating with patients. And then finally, just in terms of thinking about coordinating with other healthcare partners, if you're coordinating with a specialist or nursing facility, that you're thinking about the telehealth platform and the equipment that you're all using, and making sure that it's at least interoperable, or thinking about using a primary platform for that. And Ty, I'll leave it off for you if you have any other thoughts.
Yeah, I think just the one thing I'll add, and I know Greg mentioned this at the beginning, is that, you definitely don't want to bite off more than you can chew, and just really focusing on what are the bare minimum needs that I need to implement telehealth, rather than just buying any and all of the things that could potentially help you. However, I do think it is important to think about what are some of those that first bullet point, primary equipment for providers and patients that could be beneficial. And so I just wanted to throw out examples. So Greg mentioned remote monitoring devices, but it also could be as simple as a scale that you would want to maybe purchase or have on hand for your patient to have at their house, or a blood pressure cuff that could potentially plug in. There are, just very basic equipment that could also be purchased and utilized to help you with that consultation, or with that clinic, or that clinical encounter, that could be beneficial and make a more successful encounter with your patient and for your patient. And Greg has some resources as well, and there are outlines that show kind of what equipment could be, but I guess just giving some even equipment that oftentimes one of the things that we see is that clinics will contact us and say, well, I have this, cart system that I've purchased all of this equipment for, or I was given a grant to purchase all of this amazing equipment and I have no idea how to use it or where to even start. And I think, one of the best pieces of advice that we could give is just to start off small, focusing on what is it that you truly do need to implement something, and then going from there and figuring out what could be useful. And it doesn't have to be this extreme expense or technology that you need to put in place. It could be, something as simple as a scale, a blood pressure cuff. So I guess that's what I would add to this question.
Great, thank you. So discussion topic number 3, what are common implementation pitfalls and how can they be avoided? I'll turn it to Dr. Bush.
So I think a lot of this we've already started to touch in on. A lot depends upon what sort of practice you have, what are your patient needs, and then just trying to plan how do you work that into your workflow. A lot of people, and I've seen a lot of primary care docs have successfully gone to 100% telehealth. Others have this hybrid version. Clear communication with the patient is very important. And again, with the Zoom platform that the state is providing at no cost to our providers, you can even build certain instructions into the invitation that you would send out to the patient, helping them to walk through this. Having the backup plan. So if you find that you're having a very bad connection, say with the patient that has minimal, unstable internet, knowing that here, I'll just keep you up on my electronic health record and let's just phone. And so again, it's a combination. There's a lot of flexibility that's here now, thanks to the changes that CMS has made. So those are the things that we've seen mostly. And I think with the simpler platforms that we've had, in the old days when we had bridges and things like that, you know, you almost had to have a technician on board. But with the internet-based, web-based platforms like Zoom, it's really become very, very simple. And a lot of it's just the willingness to take the 15, 20, 30 minutes to get familiar with it. And that's something that our telehealth network can help you with training, getting through the first couple of meetings, and then people find it goes very easily. So over to Greg now.
All right, thank you. And yeah, and just to reiterate, we are certainly here and available for any training and technical assistance around implementation. And kind of just to highlight some of what Dr. Bush has already mentioned, the big thing with implementation, and this is the big thing with any and all implementation, healthcare or otherwise, it's the planning and the understanding your needs and your capabilities. And this kind of goes off to not biting off more than you can chew. You know, and right now in a limited time frame, obviously, you know, again, it's going to be hard to do a really deep needs assessment. But what we do right now, and actually what's kind of almost beneficial about having to deliver telehealth right now with COVID-19 is it gives us a really clear idea of, well, what do I absolutely need to do to see my patients? Or for my facility that I'm a part of to see patients. And that actually helps clarify a little bit of the process that we need to go through right now. Because right now, patients really just need access to care. And that's just a really good place to start off with. But there's just, in terms of really thinking about, you know, what you can and can't do in terms of capabilities, and what can be done via telehealth and what can't, and then what are your technological capabilities, what are your bandwidth capabilities, and then also what are the patient needs and capabilities, and for any established patients, you're probably going to know them pretty well, but we haven't really had to think about, okay, well, you know, I'm a provider in Laramie and I have a patient in Centennial and I've never had to worry about their internet connectivity until just now. And do they have internet connectivity, or am I only going to be able to do telephone visits with them for the moment if they are meeting from home? And that just kind of goes into considering the patient on a larger term with the patient communication and education. And then, and in terms of thinking about that, having some of that patient education in an easy to access place, you know, even though clicking a link is very simple, and the vast majority of patients are, you know, at this point, older and younger, you know, have FaceTimed with family members, they're using Zoom, or they're using Messenger video already. So they're going to be, you know, video chat shouldn't be a completely alien technology to them, but knowing exactly what they need to do so that they don't have to think about it or consider it. Do I need to download an app? Do I need to click a link? When do I do it? How do I do it? What are those steps? And having that set language. If you have a website, having it on your website. But at the very least, having set language in communication going out, either for the initial invite or appointment reminders and things like that. And as Dr. Bush mentioned, having your backup plans, telephone codes are open right now for the vast majority of providers. Something to also think about in comparison with in-person visits. With in-person visits, if somebody can't make an appointment, you just reschedule. And if that has to happen with a telehealth appointment, it certainly can. It really doesn't need to right now, though, with the open telephone codes for your ability to do that, but not wasting a lot of time. You know, a really big pitfall for telehealth is if you're having a tech issue and you spend 10 minutes trying to fix it so that you can then meet for 10 minutes. If there's an issue and it can't work out, cut it, either reschedule, do a telephone meeting, something like that. And then really just thinking about, staff preparation and learning curve. The more preparation you have, the more training, the more everybody's on the same page, the better it's going to run. And then there is going to be a learning curve. It's going to be there. I think anecdotally, we are hearing that the vast majority, 70, 80% of all telehealth meetings are running incredibly smoothly on both ends. There are going to be patients that aren't really ever going to get it, but they're going to be very, very, very few. The people that might have trouble connecting for their first few meetings, that's just going to take a little bit of extra a little bit of extra education, and that's fine. But I think just considering your own approach and your own attitude, if you are frustrated with telehealth and you are communicating that to patients, patients are going to think telehealth doesn't work. And, 2 or 3 years from now, or I don't know, 6 months from now, whenever, if we don't have to be doing telehealth, that's fine. Patients can come in. But right now, if there's a patient that needs access to care and either telehealth is their only option or it's really what they would prefer, their best option, we don't want to dissuade them accidentally just because we're a little frustrated with telehealth. So considering that as well, I think is helpful. I'll leave off to Ty.
The only thing that I will add, again, is one of the things that we see is that we definitely have a lot of buy-in. People, what we're seeing from providers and healthcare organizations and administrators and from all levels really of health entities is that there is buy-in and they get the concept and the idea and like telehealth. It's the implementation piece that I think is sometimes the barrier to telehealth being available in Wyoming. And so I think one of the things that I would say is just how can they be avoided? Just pick one piece of your clinic, maybe, and start there and try to figure out how you're going to implement telehealth with, this patient or this, follow-ups or something like that, where you're not just going in and saying like, now we're going to implement telehealth any and all places within our practice. I think just starting small and figuring out the nooks and crannies of how things are going to work, the policies, the procedures, your workflow, and doing it in like more of a pilot setting and then expanding it as you go from there. Or if you have one provider who's in your organization that is willing to try, start with just that one provider and then allow them to pass on their lessons learned with the other providers in your clinic. One of the things that we have seen with the Albany County Community Health Clinic is that's one of the things that they started with, is that they worked with 2 mental health providers that were, and I don't know if they're on the call today, but they've presented on our webinar, and all of our webinars, this is kind of a plug, have been recorded, so you can go back and listen. But they started with 2 providers that were really interested in this and saw a value and wanted to try it out. And so they were the ones that kind of started moving that process forward within their clinic, and then was able to articulate that to the other sites that they are a part of, to their administrative staff, to other clinicians within that setting. And so that's one of the things that I would suggest, is to kind of to pare things down and just to start small and then expand from there and use those lessons that you learn to better the practice further on.
Great, thank you. And that brings us to our last discussion point. Why should organizations continue telehealth services beyond COVID-19? Dr. Bush, if you could get us started, please.
Sure. And I've been trying to really promote telehealth, as I said, for 13 years. For example, you just think about with the nursing facilities, if there's been a change of condition, a lot of places will call the ambulance, they'll transport them to the emergency room where they don't have their record. They do an expensive evaluation and move them back. I think the fact that now you can keep the patient in the nursing facility with the nurse at the bedside, and the physician can evaluate changes of care. I think a lot, this is the way healthcare has been trying to move. Again, I go back to Medicare. I think that was one of the big barriers for a long time is people were afraid they weren't going to get paid. They thought they wouldn't be allowed. I don't, listening to President Trump and Seema Verma at CMS, I do not think that these things are going to be reversed. Probably the telephonic will be reversed, but not the telehealth. So we've really been moving in this direction. As I talked about at the very beginning, especially in a frontier state like Wyoming, this is really important, not only for primary care, but specialty care. You know, we've grown so used to the fact that if you are seeing a specialist down in Denver, you're going to just have to jump in the car and take a day off of work, take a day out of school to go down for a 15-minute follow-up visit. It's very wasteful of everyone's time and money. And so really, we're hoping we can bring the specialist to the patient rather than make the patient go to the specialist. So this is really, and like I said, I think as a state level, we really want to improve the access to care. And the example I used earlier, where you can have the primary care and the specialist in the same visit with the patient, is actually better than in-person care in many ways. And so if you can have everything done and ready prior to the visit and just a little planning, you can actually provide better care than you could in person sometimes. So I think that this is really the way things are going. We've had a great opportunity. You always have to think of anything with the pandemic and a healthcare crisis as an opportunity. But I do think this is really an opportunity for every provider of healthcare, no matter what type, to move forward and without the fear that this is going to be taken away long term. Greg?
Yeah, and I do think the biggest barrier to the fact that telehealth hasn't really just become universal has been some hesitancy on CMS's part and then on other payers' parts in terms of reimbursement, and that's something that Wyoming Medicaid has done such an excellent job of for years, which is keeping that really wide open, because obviously if you're not getting paid, then it's going to be really hard to deliver care. But and I do think I think my favorite analogy that I have heard is it's going to be really hard to stick the toothpaste back into the tube with the open codes now. Some of it will certainly change in the future, but it's going to be hard to revert back. Just in terms of a technology standpoint, this is where healthcare is going. Just like 10 years ago when electronic health records came on, and that was its own thing to get adjusted to. They haven't gone away. We haven't reverted back to paper. And it's going to be the same thing with telehealth. Technology is just going to keep getting better, especially right now as payers and as CMS is seeing the benefit. Those codes are probably going to stay open to a certain extent. It certainly does improve your suite of care, which Dr. Bush has really touched on. It does allow for that additional specialty consultations for patients, and it also allows more creativity in treating patients and more ability to follow up, more ability for care coordination. You're talking about just an extra tool in your toolbox, which, and thinking of it in terms of tools, even if down the line, your practice doesn't need to use telehealth all the time, you don't want to get rid of that as an option, especially, with the availability of, Zoom, HIPAA secure Zoom accounts from the telehealth network. If somebody does need to be seen via telehealth, even if you're only doing a few visits a month, that is really beneficial. Because weather, emergencies, sick leave, those are all less of an issue with telehealth. And it gives you that extra tool, particularly for the hard to access patients, and keeping people in the community. And then just to touch on really where we're at with COVID-19, there's nobody really knows what the consequences are going to be with COVID-19. Nobody even really knows when we're going to be able to change what we're doing in terms of COVID-19. You know, there's been a lot of talk of the second wave and when and if and what that looks like. And then there's also just how people are going to approach their whole lives, but also healthcare in light of COVID-19. Behavior is probably going to change. And thinking about in terms of disease and infection in particular, both patients and healthcare facilities are going to probably strongly consider, you know, should telehealth be our first line of defense for this? If somebody's showing flu-like symptoms, a telehealth visit is probably a really good first bet. You know, for follow-ups, telehealth, you know, is a really good first bet right there, just in terms of like keeping everybody safe. And that's a high possibility moving forward too. So I'll leave any last considerations to Ty.
I don't think I have anything else to add to this question. I think Greg and Dr. Bush did an excellent job at describing. I mean, we at the Telehealth Network and the Wyoming Department of Health and the Telehealth Consortium clearly feel that telehealth is one way that can improve access to care to Wyoming residents. It doesn't necessarily mean this is replacing your full practice at all, especially when times change with COVID, but it is another option to better serve your patients if the ability to come into your clinic physically is a barrier to care.
So, and I'm just going to start moving because I think we were going to questions next, and I see April G. Wyoming already put a question up. Do you want me to take first stab at that one?
Sure. Yeah, why don't we start with April's question, and then we do have a couple of questions that were submitted in advance, but yeah, yes, please, Dr. Bush, go ahead and address that question. And thank you, April, for submitting. Anybody, please make use of the chat box to submit your questions. And then for those of you joining by phone, please feel free to pose questions verbally as well. But yes, please, Dr. Bush, if you would address that question.
So for those who are on the phone, April asked, we've been told the provider must be licensed in the state where the patient resides. How do you see the process going forward with the specialists who are from another state seeing the patient? Excellent question, and there are actually two different scenarios. One is we have a Wyoming resident who is seeing a specialist in, say, Utah, Colorado, Montana. I've been very lucky to work with Kevin Bonenblust, who is the executive director for the Wyoming Board of Medicines. And we have already set that up so that a specialist from another state who is occasionally like consulting does not need to have a Wyoming license to see the patient because they are seeing them in consultation with their local physician. And so they can do like up to 12 consults in the state. Now, it's a little different if the patient or if that physician is routinely providing services across the board. However, during the COVID crisis, even that has been relaxed. But normally we would say, if you are, say, providing ongoing routine visits, more than, say, 12 visits a year to the people of Wyoming, we would prefer you to, you really should have a Wyoming license. But say you are a gastroenterologist at University of Colorado and you are seeing one patient with a pediatrician, you do not necessarily need to have that. If you are a Wyoming provider and you are seeing a patient from another state, then you need to turn around and look at that state's Board of Medicine rules. Most boards of medicine have really relaxed things during this crisis. And so, but, I don't want to speak for South Dakota or Utah Board of Medicine, but I would say that most boards of medicine have really relaxed the interstate regulations. So it's a very good question.
Dr. Bush, I just wanted to add to that real quick. There are also, in addition to that, already in place, and there's legislation for more of these, but there's the Physicians Interstate Licensure Compact, which helps facilitate an expedited pathway for licensure, and that exists for physicians. There's a licensure compact for speech language pathologists, and then it was introduced in legislation, didn't make it through this time. Also one for mental health as well.
Great, thank you.
So, Hannah,
Why don't we go on? Oh, go ahead, Brenda. Sorry.
I'm sorry, Hannah, I didn't know if you saw there was another follow-up question that was in the chat.
Yes, I would like to move on to that one from Temi. Thank you for submitting. So on that, can their provider do telehealth with snowbirds?
So I just want to make sure I'm answering this correctly. So you're saying, like, you have a patient in your town and then they spend the winters down in Arizona. Is that sort of what you're asking about? If
Yes.
you have an established relationship with the patient, yes, you can provide telehealth, especially in the time of COVID. So if it really depends on how much time the patient spends, but typically I would say if the patient considers himself a Wyoming resident and they're out of the state, you can still provide telehealth.
Great, thank you. And then just to go back to some of the questions that were submitted in advance, and please, attendees, feel free to keep submitting those questions in the chat box, or if you're on the phone, please speak up verbally to pose your questions. But the first one that we had in advance was, what are the major differences between Medicaid and Medicare reimbursement?
So currently at this point in time, Medicare actually very closely mirrors Medicaid's billing. There are some slight differences, like in place of service codes, et cetera. So sometimes the way you code and bill for them is slightly different. We have on our telehealth network webpage a sort of COVID links, and we have more details about the coding. So, but typically, even with Medicaid or Medicare, any service that can be provided telephonically will get reimbursed, but you want to think a little bit about the coding. And it also depends, of course, if you're billing on a HCFA or UB.
Great. And then the other question that we had submitted in advance was, what are some ways that administrators can help their providers prepare for the transition to providing telehealth services?
Greg, do you want to take that one? You've worked a little bit more with them.
Yeah, so I mean, a big thing, on the administrative end is really being able to understand the nuts and bolts of the process, and I think what we like to think about, for administrators is like, how easy can we make it for the provider to be able to see patients as much as possible and as easily as possible. And so we actually, a lot of the technical assistance that we do, we work with a lot of providers directly, but we also work with a lot of administrative staff as well. And in particular, just thinking about it from a workflow and an implementation standpoint, being able to understand precisely what goes into the telehealth encounter. What do you need to do and in terms of scheduling, and really just getting those meetings started and running smoothly. And so actually a good example of this, and in terms of making sure that everybody's on the same page, and I think this is a really good place for an administrative staff to step up to be really supportive to providers in, is understanding any of the idiosyncrasies that a telehealth platform might have. So for example, Zoom has two different options for creating meeting invites. You can use a personal meeting ID for all of your meetings, which is the same meeting ID, or you can generate your own meeting ID, which is totally different and random. And if your administrative staff and your scheduling meetings under separate meeting IDs every single time, and your provider's trying to connect on the same meeting ID, they're, you know, the patient's going to be in the right meeting room, and the nurse might be, and you might be, but the provider's not going to be connecting to the right meeting. You know, so understanding those processes, being able to explain them to the provider, and then also being able to support the patient. A provider, you know, it shouldn't really have to fall on providers to have to provide technical assistance in call. You know, obviously, if providers are having their own technical assistance troubles, you know, that's something that you can discuss not in meeting and do test calls for. And test calls, I think, are wonderful practice. You know, before the meeting, you know, in terms of any patient education, if a patient needs a test call or anything like that, being able to get patients acquainted with the platform, if need be, would be tremendously helpful as well.
So I see that John Engst wants to ask 2 questions.
Yes, thank you, Dr. Bush. My question is involving maybe a bit of political calculus. Well, first off, I am a board member of a FQHC that is in Wyoming, and most of our connections are with HRSA, obviously. But I'm asking the question in regards to what's the surety of funding of the telehealth network through this biennium, and only in the sense of, obviously there may be funding in our case that would come down from HRSA, but for the viability of the operation of Wyoming Telehealth, and maybe Greg would have an answer for this, what is the guaranteed quote unquote funding model that you have from the legislature and relative support to that? And then I'll ask my second question after the response.
Well, you're right. That's a political question. So we're good through this year, the upcoming year. You know, our biennium starts in July 1. You may be aware that the Management Council of the legislature has moved telehealth as an interim topic to priority number 1. And I've been getting some questions from the legislators. And the biggest part is educating them on what has already occurred. And again, I'm very proud that the way the Telehealth Network, Wyoming Medical Center, CRMC, all the providers of telehealth services are working together, and we're really speaking as a unified voice. I think it is very important that you, now, as I always have to say, I, as a state employee, I'm not allowed to lobby. I can certainly answer questions and I can educate legislators, but I cannot lobby. I think it is very, very important for all of you guys as stakeholders in Wyoming who are not barred from lobbying to really let your legislators know what you're using, how valuable you're finding this, et cetera. Because as you know, we're facing significant budget deficits coming up thanks to not only energy prices dropping, but the shutdown. And so I think it is really, really important that everybody go out and speak to their legislators about what's happening. A lot of times they're saying, oh, we need to build a network. We've got a network. We've got a network with thousands of providers all across the state, and it's all interoperable. But the question really needs to be is how do we continue to fund and support the network that we've created? Does that answer your question?
It certainly does. If you don't mind, I'd like to add one comment and then my second question, mindful of the time. I've had the advantage of telehealth from the standpoint of being a consumer with MD Anderson, being a lymphoma patient. And the fact is that when you talk about COVID being a spike for the necessity of telehealth, the fact is that the maintenance post-op and post-protocol for an individual that's a consumer like me is invaluable, that I can have all of my information sent through a machine that goes into the phone, goes down to Houston, and that the maintenance and monitoring is invaluable. So I don't see a decay in need of service via telehealth for many individuals that would be consumers in the condition that I found myself in. The second question, and I hope this is something that's applicable to those who are listening, and that is that when you talk about the costing for telehealth, obviously during HRSA, and maybe I'm more familiar with that being the treasurer for the board of our organization, that there are rules in the Federal Register now that we're getting, and they change seemingly every day from HRSA and from the feds as to reimbursements and how you allocate costs for an encounter as an office visit. Have you had any white paper or anything in regarding to how you want an organization, be it private or public, or HRSA or FQHC in our case, has any guidelines that have been provided within the state about allocation of costs when it becomes an office visit via telehealth?
So there have been new, I'll go in two different directions here. First, and thank you for bringing up some of that, as you know, there have been several funding sources that have become available. Some through CMS, some through HRSA, some through the Department of Agriculture. Again, if you go to the COVID web pages, you'll see some links to funding sources that are available. They're very detailed, very complex, but there are literally billions of dollars that are available out now, some directly to providers and some to organizations. So I'm not going to try to second guess for FQHCs, but I do know that there is a lot there, and I think the Primary Care Association would be a great resource for you there. And likewise, I would probably refer you to the Primary Care Association about the cost allocation question. I think that's a little bit outside of my wheelhouse.
Well, I'd like to make one final comment, and I know everybody else wants to get online here, and that is I believe that telehealth will be as familiar and ubiquitous as we will see with 30, 40 years ago, nobody used an ATM. Now, who doesn't? And I think that with the structure of what we have in Wyoming, this is a compliment coming to you, that I think we're in good hands, and we will see that telehealth will end up being as per usual as any other thing that we find in a clinic. So thank you very much.
Great. Well, thank you, everyone. Thank you to our presenters and all of our attendees today. We're at 1 o'clock now. I will be sending out an evaluation about this webinar. And within that evaluation, there is a box that we are looking for future topics to explore as you know, telehealth develops and grows within our state. So please take the time to fill out that evaluation. We would love to hear your thoughts. With that, I'll say thanks again and have a great afternoon, everybody.
Thank you.
Thank you.
Thank you.